So welcome everyone. I am Dr. Kerry McCord.
I am Dr. Wally Schmitt. Welcome.
So this is a special webinar presentation on thoughts on the COVID-19 outbreak. And I'm going to let Dr. Schmitt begin.
Well, we're all, as we know, in the middle of an unusual circumstance in our lifetime. So there are a number of things that have been going on about this coronavirus 2019 or COVID-19 outbreak. As you might imagine, we've received numerous questions from doctors and patients regarding the COVID-19 pandemic. In that light, we decided to prepare some fundamental and salient thoughts on the outbreak and how we as natural health care physicians might be prepared should we advise or treat any of these patients. SARS is severe acute respiratory syndrome. There are many healthcare practitioners commenting on how to treat COVID-19, and most of the information we have seen is presented by clinicians who have never treated COVID-19 or the SARS 2003, which is now called the SARS-CoV-1 virus, nor have we treated any of them. But we have a lot of information coming at us, and it's hard to discriminate what's to pay attention to and what's not to pay attention to. We're trying to give a little bit of a background about the immune system so we have a little bit of understanding of how this COVID-19 epidemic or pandemic is taking part in patients' physiology. So we're going to have the information that follows is provided to discuss the nature of COVID-19 with a focus on possible avenues of clinical investigation should you encounter one of these patients. Chances are you probably won't have any of these patients come into your office because they would be under quarantine once they were diagnosed, but you may have some patients come in. You may have some patients in your family or friends or people who live with you that have this, and under any circumstances, we want to have information available that's accurate about the immune system and see if we can then translate what we know about the immune system into any patients we might encounter, whether we treat them directly or maybe by over the phone or telemedicine of some sort. So to be clear, we have not treated, Kerry nor I have treated any COVID-19 patients and are not suggesting any specific therapeutic applications. But rather, the purpose of this presentation is to provide some thoughts on possible avenues of clinical investigation should you encounter one of these patients. The directives and guidelines of the CDC and various governments and their agencies are well described elsewhere. We're not going to repeat those there. There are plenty of places you can find those. We recommend that you access and read these guidelines and directives to help slow the spread of the pandemic. We're going to take a little different approach. The SARS-CoV-2 COVID-19 reference that we're basing a lot of this on is listed here. I would recommend that you write this down or you copy it and go to this site later. We've taken a number of excerpts from this site. It's from the Internet Book of Critical Care. There's a chapter written on March 2nd, 2020. That's a couple weeks ago. And this is a constantly changing pandemic, and the changes are coming out every day. But this was a very solid chapter on the background physiology of this virus and its disease, the COVID-19 disease. And so we're going to refer to that along the way and recommend you look at it as well. It's very solid and comprehensive, yet very brief overview of the physiology and the clinical applications. And it was written for critical care doctors, but there's much there, especially in the first third or half of it, that we could employ ourselves and understand this outbreak. Now let's talk about the immune system a little bit. It's generally recognized that there are two parts of the human immune system, the innate immune system and the adaptive immune system. This becomes really important to understand, and really one of the main reasons we're doing this webinar is because people keep talking about got to support the immune system, got to support the immune system. We need to know what part of the immune system needs to be supported. And that's why we're going to kind of review some physiology and some background material that we've taken from the immune system webinar series we did a year ago or so, and put that in context of the COVID-19 outbreak. There are two parts of the immune system, the innate immune system, which is inborn, and the adaptive immune system, which is acquired. The innate immune system, inborn immune system, is non-specific, has non-specific response, and the adaptive immune system, we're going to simplify a little bit and talk about Th1 and Th2 pathways, have specific responses to specific pathogens or specific substances. The innate immune system is the body's initial response to eliminate microbes and infections, and it happens immediately or within hours after the pathogen is identified. The innate immune system, as I say, is inborn. It's non-specific. Every pathogen gets the same approach. Every toxin, every allergen gets the same approach. There's a non-specific approach, and the innate immune system that reacts to something can trigger a complement cascade to start the initial body fighting the infection. The innate immune system's primary role to recognize self versus non-self. So it recognizes, hey, this isn't part of us. We got to do something about it. Now, the adaptive immune system is why a cold lasts about a week. The adaptive immune system is acquired. We're not born with it. As we encounter pathogens and interact with our environment, we have an adaptive immune system which develops over time. And there are a number of arms of the adaptive immune system. We're going to focus on two, one called the Th1 and one called the Th2. The Th1 pathway stands for T helper lymphocyte 1. Th2 stands for T helper lymphocyte 2. These two different pathways are different in their response, both operate at the same time. If you have a pathogen, Th1 is a cellular response where you have the phagocytosis. So the pathogen is engulfed and so called eaten up by the phagocyte. And the second response is a humoral response where the body makes antibodies, the immunoglobulins, and so on, which help the body to tag the non-self pathogens and recognize them, so that Th1 phagocytes know where to go and chew up the enemy. So we have these two different responses. In fact, the innate immune response triggers the adaptive immune response. They run parallel only after the innate immune response gets the adaptive immune response working. It takes 5 to 7 days after encountering a new antigen for the adaptive immune system to reach full activity. Thus, why a cold lasts about a week. We come across a new virus like a cold, we haven't seen it before, and the body starts to crank it up, and we get initial response, and slowly over a period of 5 to 7 days, our adaptive immune system kicks in and develops the full bore. When we get full bore adaptive immune system, the body then can specifically attack that pathogen, that cold virus, for example, and about a week after a cold comes, we get better. Now, some people will have the innate immune system knock something out right away, but more often than not, it takes about a week for a cold to get better, as you all are aware. So this is very important to understand when we're dealing with the coronavirus that we're dealing with now and the COVID-19 infection. It takes a while for the body to ramp up to get to full bore activity to fight off this virus. And so once the innate immune system recognizes it, we get an innate immune response, and then slowly the adaptive immune system response cranks up to its full level of activity. There is an important point to know about this virus. So there is the Internet Book of Critical Care where we've taken some of this information from. Dr. McCord.
So as you see, there was a chapter in the Internet Book of Critical Care on COVID-19 written by Josh Farkas. Josh is a medical physician, assistant professor of pulmonary and critical care medicine at the University of Vermont, a graduate of Cornell University Medical School, internal medicine residency at Dartmouth University, pulmonary and critical care fellowship at Albany Medical Center, and a clinician educator in the combined medical, cardiac, and neurological ICU. So his background is pretty significant relative to this subject. I want to read this little opening. That's what the prior slide is, what you'll see when you open up the Internet Book of Clinical Care. If you go to the entry, Josh wrote, as COVID-19 has exploded, so has the amount of information about COVID-19. There are currently over 700 publications regarding coronavirus listed in PubMed within the past few months. More are being released daily. Many haven't been cataloged on PubMed yet. That's really important to see. So here's what he said. COVID-19 is a non-segmented positive sense RNA virus. COVID-19 is part of the family of coronaviruses. It's a whole family of these guys. Cold virus is part of it. COVID-19 is most closely related to SARS. This contains 4 coronaviruses which are widely distributed and usually cause the common cold. but can cause viral pneumonia in patients with comorbidities. SARS and MERS, MERS is Middle East Respiratory Syndrome, these caused epidemics with high mortality, which are somewhat similar to COVID-19. COVID-19 is most closely related to SARS, as we've discussed. It binds via the angiotensin-converting enzyme 2, ACE2 receptor, located on type 2 alveolar cells and intestinal epithelium. The things in gold, Hamming 2004, is where the reference for this is. This is the same receptor as used by SARS, hence the technical name for the COVID-19, SARS-CoV-2 virus. So COVID-19 is mutating, which may complicate matters even further. Virulence and transmission will shift over time in ways which cannot be predicted. New evidence suggests that there are roughly 2 different groups of COVID-19. This explains why initial reports from Wuhan described a higher mortality than some more recent case studies. So here's the immune system, again, innate and adaptive.
We can look again at the adaptive immune system and see that we have 2 arms, the Th1 and Th2 arm, and the one is the phagocytosis and the other is the antibodies, both of which must be working together. When there is an infection, we have a tendency for the Th1 to be higher and the Th2 to be lower. The phagocytosis needs to be cranked up for us to fight infections, and the Th2 needs to be operating in the background. But when there's an infection, typically the body shifts into a Th1 mode, with the Th2 making the antibodies as part of the game, but it's playing a lesser role. So we start with the innate immune system. It recognizes self between non-self, and then it activates the adaptive immune system. We're going to then have the a naive T cell. These are all lymphocytes. These are the 4 pathways for naive or Th0 T cell polarization, adaptive immunity. The adaptive immunity starts with a naive T cell. It's a T lymphocyte. It can go in a lot of different directions. This shows 4. It can go at least 7 different directions. We know we have what we call 7 different T cell polarizations at the present time. And the 2 we're going to focus on are the Th1 and the Th2. Cytokines direct the immune response, and Th1 responses are guided by IL-12. They're more or less against living things, bacteria and viruses, as we're concerned in this case, and fungi. Th2 responses are guided by interleukin-4 and the Th0 cell, the naive T cell, under the influence of interleukin-4 becomes a Th2 cell. And this is primarily to non-living things, and by the way, also parasites, things that live in hollow organs in the body. Foods, pollens, bad fats, and heavy metals also will show Th2 response. So here we see the 2 primary responses to pathogens, Th1 and Th2. The way this works is we have a phagocyte that arrives at the Th0 cell, the naive T cell, and activates it, and we'll get to that in a minute. So if we look at the Th1 and Th2 immune reactions, cell-mediated immunity, the Th1 reactions, primarily cell-mediated is phagocytosis, primarily by dendritic cells and macrophages. Intracellular immunity is the most, for most living things, these macrophages, these phagocytes will phagocytize and create the virus and the bacteria, the fungi, so on intracellularly. They'll chew it up, so to speak. And there's often inflammation associated with Th1 response. Th2 response is antibody mediated. It helps B cells or B lymphocytes produce antibodies, IgG, IgE, etc. And more or less, these are the reactions to non-living things like foods, pollens, and most parasites. And it's called extracellular immunity, and includes the traditional allergic reactions. But we have to have the antibodies going to be able to tag the pathogens so the phagocytes know where to look for them, if I can say it that way. So let's now look at this picture here. Here we have an antigen being presented to the naive T cell. This antigen, this is the dendritic cell. It looks like a starfish-shaped cell, and the dendritic cell is called an antigen-presenting cell. Depending what it is has phagocytized, it will process that and then activate a naive T cell to become a particular type of cell. If it's a pathogen such as a virus, it will activate the naive T cell to become a Th1 cell, which will then trigger off cellular response or phagocytosis, and reactive oxygen species can be as a result of that, or free radicals can result as that part of that process as well. Technically, the coronavirus is supposed to be called the SARS-CoV-2. The 2003 SARS virus has been renamed the SARS-CoV-1, and so the clinical illness is called COVID-19.
So let's look at the pathophysiology. The primary pathology is ARDS. ARDS stands for acute respiratory distress syndrome, characterized by diffuse alveolar damage, including the hyaline membranes. Pneumocytes with viral cytopathic effect are seen, implying direct virus damage rather than a purely hyperinflammatory injury. Emerging evidence suggests that we're somehow not on that. There we go. And I'm going forward. Wally, can you take me back to that other slide?
You should have it
Emerging
there.
evidence suggests that some patients may respond to COVID-19 with an exuberant cytokine storm reaction with features of bacterial sepsis or hemophagocytic lymphohistiocytosis. Hemophagocytic lymphohistiocytosis. Somehow I'm getting this change to go multiple times. Hopefully it'll stay here. Wally, if you could go back. I don't know exactly what's happening.
Well, I have the HLH slide on my screen.
Okay, very good. So you go ahead and change the slides as we go through to avoid this technical issue, if you would.
I'll do that.
So hemophagocytic lymphohistiocytosis is primary familial and secondary to infections. It's an overwhelming activation of normal T cells and macrophages. The immune system damages the patient's own tissues. This invariably leads to clinical and hematologic alterations and death if untreated. Once again, emerging evidence suggests that some patients may respond to COVID-19 with an exuberant cytokine storm reaction. Very important for our next discussion. And Wally?
I have the clinical markers slide on my screen. Now let's move forward. This one here. Can you see it, Carrie?
I can see immune system. Now I can see clinical markers.
Okay.
Clinical markers of this may include elevations of C-reactive protein and ferritin, which appear to track with disease severity and mortality. There seem to be different stages of illness that patients may move through. The replicative stage, which is in that initial stage of the incubation period, and the adaptive immunity stage. And Wally, why don't you take it from here?
Okay. So we're going to talk about, there is, interestingly enough, with so many people working from home these days, there is reported a lot of excess internet activity. And so sometimes some of these things we're dealing with little technical glitches are maybe not even our fault. So I apologize for that. So the patients can go through the replicative stage or the adaptive immunity stage. And one of the things that happens is elevated CRP or elevated C-reactive protein has been found in these patients. Elevated C-reactive protein, which we'll get to more in a bit, is associated with elevated interleukin-6 and or elevated interleukin-1 beta and or elevated tumor necrosis factor alpha. These three cytokines, all of which have powerful inflammatory nature, are really the reason that the CRP is elevated. So we have the immune system, we have the innate immune system, which activates the adaptive immune system, and it creates the Th1 response and the Th2 response to the infection, but primarily a Th1 response. And as a result of the response to infection, the body's fighting the infection, the tissue debris that's secondary to the infection, we get a lot of inflammatory response as well. So, Carrie, you want to try and take it back again?
One more time.
Okay.
So the replicative stage. Viral replication occurs over a period of several days. An innate immune response occurs, but this response fails to contain the virus. Relatively mild symptoms may occur due to direct viral cytopathic effect and innate immune responses. Cytopathic effect, of course, is structural changes in host cells that are caused by viral invasion. An adaptive immune response eventually kicks into gear. This leads to falling titers of the virus. However, it may also increase levels of inflammatory cytokines and lead to tissue damage, causing clinical deterioration.
It's been observed that the time lag between the onset of the symptoms, which is the initial innate immune system response, and the adaptive immune system response is about 4 to 5 days, which fits right in our timeline. We talked about it takes 7 days, 5 to 7 days for the adaptive immune system to crank up to full bore. This fits right in with that timeline. So the adaptive immune stage in the COVID-19 seems to kick in about after 4 or 5 days, and patients do okay for 4 or 5 days. They got a cold or they got some kind of upper respiratory infection. And then those who don't do well, it's when the adaptive immune system kicks in after that 4 or 5 days that things take place in a negative way.
This progression may explain the clinical phenomena wherein patients are relatively okay for several days, but then suddenly deteriorate when they enter the adaptive immunity stage. So the game changes as COVID-19 progresses through these stages. Our job is to identify the patient's needs, always, both initially and at the onset of symptoms. And then if we have the opportunity to treat those people who might be in our family or in our inner circle, we'll probably not have them walk into our office considering the advice from the CDC. And then we'll reevaluate our approach if and when a patient's condition deteriorates. So we're using an initial approach and evaluating what nutrients might support them, and then changing that as time passes. There are many immune system supporting nutrients and phytonutrients, and Dr. Schmitt will discuss those now.
So one of the things that I've noticed on my spam filter, between 3 and 5 times a day for the last 3 weeks, I'm getting messages that are caught in there, and some get through because they're people that I normally communicate with, about what you should take to strengthen your immune system, what you should take that's good for your immune system, immune support nutrients, buy these from me, get my company's version, get my book's version of get what you need to support your immune system. Well, when someone tells you this is good for the immune system, you have to ask the question, what part of the immune system? But clearly, considering nutrients that support the immune system function, one must determine the individual patient's immune status and test for patient need. All immune system support nutrients are not the same. To support the wrong part of the immune system could result in doing more harm than good. And that's what we want to address. There's much misinformation there amongst people who are not familiar with immune system patterns. They're not familiar with innate immune system. They're not familiar with the fact that the innate immune system activates the adaptive immune system. There's a Th1 immune system, a Th2 immune system, and adaptive immune system. And there are other forms of the the adaptive immune response. And something that's good for the immune system depends where your immune system is. What is going on with your immune system? What part of the immune system? Is it the innate immune system that something is good for? Is it the adaptive immune system something's good for? If it's the adaptive immune system, is that Th1 arm, Th2 arm, Th17 arm, T regulatory cells, or there maybe at least 3 other pathways that could take? What part of the immune system? And people are actually recommending nutrients which would be inappropriate based on the fact of how the coronavirus, the COVID-19 coronavirus works. So what we want to do is give some background to that so you have a little bit of sense of how this virus fits in with the overall understanding of the immune system function. The question is, does the patient have a lowered immune system function or an increased immune system function, or combinations of both? Because when you got these different parts of the immune system, one could be up and the other could be down. You might want to push one down, the other one up. What if you're supporting? I think just by saying that, you can see the ludicrousness of saying, take this formula, it's good for the immune system. Which part? If you push the wrong part up and it's already too high, it's going to make it worse, as we're going to address. So you have to have a way of understanding what's wrong with the patient, and then a way of assessing it, and then supporting the immune system based on their specific needs, and not just their specific needs today, but when the innate immune system kicks in, that's one thing. When the adaptive immune system kicks in, if there's a cytokine storm, it's a whole other issue. And so we have to be able to shift gears in stride as we are following our patients. In other words, does the nutrient substance we might give increase a lowered immune function or decrease an overactive immune system function? And sometimes one part's high and the other part's low. We have to balance it. But each set of nutrients may not be is typically not for all parts of the immune system. There is no such thing as immune support. You have to say, what part of the immune system are you talking about? And that's a direct quote from my good friend and former associate Sam Yannick, who is the adjunct professor at the Department of Physical Medicine and Rehabilitation, University of North Carolina, and the founder of the Cogent's Functional Immunology Program, where much of what I've learned about the immune system and his online course has been the basis for how I've been able to treat patients over the last several years. It would appear prudent to maintain a good innate immune system to help prevent infections such as COVID-19. The innate immune system is going to recognize self from non-self, recognize a pathogen, recognize a virus. It's going to jump on it and create its general response, and sometimes that's enough to knock out a bug. But it may be questionable to strongly support the adaptive immune system in these patients, because it's when the adaptive immune system kicks in that we get the potential cytokine storms and the HLH that was being talked about. So let's talk about innate immune system support. These things we're going to talk about now are there are a lot of different substances that can support the innate immune system. These are sort of good general support substances for the innate immune system to have its initial effect. Vitamin A, you want adequate levels of vitamin A in a patient, vitamin C, vitamin D, and then zinc. Now, it turns out that zinc lozenges seem to be very good. Historically, if you've ever used them, take a patient who starts to get a sore throat or something of that nature, have them suck a zinc lozenge and kind of let don't chew it up, suck it, and let it kind of permeate the entire oropharyngeal cavity. And a lot of times it'll just knock a sore throat out. Sometimes you have to suck 2 or 3 in a row, but zinc is good in the background of supporting the innate immune system. But at the time of any onset of symptoms, a zinc lozenge, and sucking on a zinc lozenge or multiple lozenges over a period of time seems to have great value. In fact, it turns out that most places now are completely sold out of zinc lozenges because other people know this besides just us. Other substances which support the innate immune system are andrographis and the beta-glucans. The beta-glucans are things like in mushroom, like reishi or Ganoderma lucidum, and also astragalus. Now, there are other substances too, but some of these substances play multiple roles, and you've got to be careful on how you identify what you're going to give a patient, because sometimes it might support the Th1, but also the Th2 response, which might not be what you want. It might support the innate immune response, but also support a another polarization of the T cell, Th0 cells. So you have to kind of be careful and just instead of just throwing immune system things at the patient. It seems reasonable. Now, again, I haven't treated any of these patients, but it seems reasonable for the background to keep our immune system strong. So use vitamin A, C, and D, and some zinc, maybe some andrographis and some beta-glucans or reishi, and some astragalus. These things seem to have a good role playing in the background to keep the innate immune system strong. So potentially, it might give us some protective effect. No one knows for sure, but these are some concepts we want to share with you. So, Dr. McCord, do you want to take over?
Yes, COVID-19 may cause constitutional symptoms, upper respiratory symptoms, lower respiratory symptoms, and less commonly, GI symptoms. Most patients will present with constitutional symptoms and lower respiratory symptoms, fever and a cough. Sources disagree about the exact rate of fever. This may relate to 2 things: methodology used in various studies, that is, whether they recorded the initial temperature or whether there was a fever at any point during the patient's hospitalization. And 2, patients included in various series. Sicker patients may be more likely to present with fever. But the absence of a fever does not exclude COVID-19. Up to 10% of patients can present initially with GI symptoms, that's diarrhea and nausea, which precede the development of fever and dyspnea. Incubation is a medium of 4 days. Now they're raising it with new studies to 5 days, and that's what Dr. Schmitt referred to. An interquartal range of 2 to 7 days, with a range of up to 14 days, hence the current quarantine periods. As I said, other reports say 5.1 days. Yes, go ahead.
There have been cases where the incubation period has been as long as 17 days. They're rare, but that's the longest I've seen. Excuse me, go ahead.
Typical evolution of severe disease based on analysis of multiple studies by Arnold Forrest. Dyspnea, 6 days post-exposure, approximately. Admission, approximately 8 days post-exposure. ICU admission or intubation, 10 days post-exposure. Which then, that suggests that the cytokine storm happens instantly and suddenly, 10 days post-exposure in an ICU, especially if it's 4 to 8 days to just get symptoms. So you look at that admission in 8 days, and within 2 days, they're in ICU if it progresses to that stage. So the complete blood count is something else that has been evaluated. The WBC count tends to be normal. Lymphopenia is common, however. So the lymphocytes, seen approximately 80% of patients, so a lowered lymphocyte count. Mild thrombocytopenia is common. Platelets, though, are rarely less than 100. So mild thrombocytopenia and lymphopenia. Lower platelet count is a poor prognostic sign, however. COVID-19 increases C-reactive protein. We've discussed that. This seems to track with disease severity and prognosis. In a patient with severe respiratory failure and a normal CRP, you must consider non-COVID etiologies such as heart failure. So here's that C-reactive protein elevation associated with, as Dr. Schmitt has discussed, elevated IL-6 or IL-1 beta or TNF-alpha. Dr. Schmitt.
And it is these cytokines, these inflammatory cytokines, that actually raise the CRP. The CRP itself is so-called acute phase protein, but it's the get to the bottom of why it's elevated, we have to look at these other cytokines, these inflammatory processes. So with that in mind, then we can look at see what happens for each of these inflammatory cytokines and what we can do to help that. This is a case when interleukin 6 is elevated, and when we do muscle testing and our AK evaluation using interleukin 6, what we want to do when interleukin 6 weakens, whether it weakens any organ in the body, if it weakens when you therapy localize the lungs, for example, or if it weakens when you therapy localize an injury, if you bang your elbow, it's an inflammatory cytokine. When interleukin 6 weakens, we want to then inhibit interleukin 6. We can use zinc to inhibit interleukin 6. Also, Scutularia bicalensis or skullcap. Berberine and antigraphis all will help to inhibit interleukin 6. You see we have a recurrence of a couple of these nutrients here in the interleukin 6 inhibition. Also, things that increase interleukin 6, we want to inhibit interleukin 6, we want to avoid overtraining, since overtraining increases interleukin 6. A lot of people are trying to work out. They work out real hard. Sometimes when you work out too hard, for whatever too hard is for you, you get higher levels of interleukin 6 and inflammatory response. Also, we want to increase parasympathetic or vagal outflow, which means we want to deal with stress reduction. TVNS stands for transdermal vagal nerve stimulation, stimulated by putting an electrode on the ear. There are tons of papers on TVNS. You can get a TENS unit and use TENS stimulation of the vagal nerve afferents on the concha and the tragus on the left ear, and this has been shown in many, many studies, starting back earlier in the 2000s, about 2005, 2007, around in there, to lower inflammatory processes, particularly tumor necrosis factor alpha. And we won't go into that, but if you have any interest in that and you have TENS units around, you should look up the protocols for that online. We also want to lower insulin, since hyperinsulinism decreases vagus outflow and hence also increases interleukin-6. So these are some things we can help with our patients. Avoid overtraining. If you're feeling sick, don't exercise. Increase the parasympathetic outflow by any of the things we know how to do, including stress reduction. And then treat the hyperinsulinism, as we've done in many patients, by looking at the things we have in QA Step 20 in quintessential applications protocol. When TNF-alpha or interleukin-1 beta weakens, we want to inhibit TNF-alpha or interleukin-1 beta, and these are nutrients which will do that. Now, curcumin, resveratrol, berberine, glutathione can have this effect, Scutellaria bicalensis, again, skullcap, and again, the vagal nerve stimulation, the TVNS. These are substances and procedures which will help to lower the inflammatory processes that are created by TNF-alpha or interleukin-1 beta. Now, that doesn't mean you throw all these things at the patient, because I have one particular patient who's inflamed and would fit this role perfectly, but the patient doesn't tolerate curcumin at all. They have access, if they take curcumin, they get an allergic reaction to it. So we have to isolate each individual patient and figure out what their individual needs are. But this is a starting place to try to cut the inflammatory process down. And these are a lot of things that can cut the inflammatory process down, but these are particularly ones you would look at for TNF-alpha or interleukin-1 beta being elevated. And in these patients, say if they're localized to the lungs with TNF-alpha or interleukin-1 beta, these are the substances you would test against. They're not the only substances that might help that, but these are the more first-line ones you'd want to try. So with that in mind, then, we can use our AK procedures to kind of determine what is specific for each individual patient's needs, and we should do that rather than just shotgunning at patients. So let's talk about elderberry and cytokines. Elderberry is something that was used in the Spanish flu of 1918, reported been used very successfully in the Spanish flu of 1918 that killed like between 40 and 60 million people worldwide. And some people are saying, why are we getting all upset about this COVID-19? Well, I think people who have historical knowledge look back a little over 100 years and realize that maybe this could happen again, and they're afraid that they don't want to take a chance on it. So that's why all the measures we're going through are to try to avoid such a pandemic as so fatal as the last 102 years ago was. But so elderberry is reported to have been used, and a lot of people use elderberry for viral infections. However, this is what we're talking about each individual patient's needs are different, and actually fighting each different virus might be different. This virus is something we don't know much about. We're learning more every day. But elderberry actually can increase inflammatory cytokines in healthy individuals. So maybe you don't want to give elderberry as a preventive. Production of inflammatory cytokines, interleukin-1 beta, TNF-alpha, interleukin-6, and also interleukin-8 was significantly increased, mostly by Sambucol black elderberry extract, 2 to 45-fold. The most striking increase was noted in TNF-alpha production, 44.9-fold increase. And although that's all true, elderberry still appears to be useful for the flu, but I'm questioning its use for COVID-19, since the pathology that kills people is this excess inflammatory activity driven by interleukin-6, interleukin-1 beta, and TNF-alpha. So keep this in mind. Nothing's good for everybody. And this is a 2001 reference you see at the bottom of the page. I would be hesitant to use it as my primary frontline antiviral in this case because of the inflammatory effects that it may have. I'm not saying it wouldn't work on somebody, but we just have to be a little more cautious. Let's now talk about cytokine detoxification. Since the major aggravating factor, the thing that puts people in ICUs, the people that creates the greatest dyspnea, shortness of breath, puts them in the hospital and puts them in ICU, is the cytokine storm. The massive inflammatory release of the white blood cells of these inflammatory chemicals, which releases more and more inflammatory substances, and then causes the inflammation, which destroys the lung tissue and causes pneumonia and death, as well at the same time, while the cytopathic effect of the viruses themselves attacking the lung tissue are tearing the patient down. If we could do something to lower the cytokine storm by possibly lowering the source of the inflammatory chemicals, inflammatory cytokines we just talked about, is a good thing. But what if we still already have too many cytokines? How can we get rid of those cytokines? Well, cytokine detoxification is performed in part of the liver detoxification pathway, particularly phase 2 liver detoxification pathways of glycination. The use of glycine to help the conversion of the halfway detoxified substances into their water-soluble form to be eliminated from the body. So in cytokine detoxification, cytokines, like all other chemical substances in the body, are detoxified in the liver. They're conjugated with glycine. As with other substances, cytokines may not be detoxified as rapidly as the body produces them, hence a buildup that could create secondary signs and symptoms. Now, if you want the full reference on this from our QA course, it's in QA book appendix page 18, and we discuss it in QA session 12 when we talk about secondary forms of liver detoxification. QA session 11, we talk about liver detoxification, and session 12, we talk about specialized parts of liver detoxification, such as cytokine detoxification. Glycine has also been shown to moderate the release of cytokines during times of metabolic stress, and this is a reference at the bottom. Glycine modulates cytokine secretion, inhibits hepatic damage, and improves survival in a model of endotoxemia in mice from 2003. And we have seen this since way back then to have glycine be useful when there's excess cytokines, especially when it's affecting the liver. Of course, we haven't really seen that affecting the lungs because we haven't seen this particular COVID-19 before, but we think it's worth mentioning to be aware of the fact that you may be able to help lower cytokines in patients when they get into the phase where they're getting excessive cytokines and moving into a cytokine storm. Glycine factors, the substances that help the body make glycine, are folic acid, really 5-methyl tetrahydrofolate, its active form, manganese, B6, and its pyridoxal 5-phosphate form, and riboflavin. Now, those of you who have taken the QA program know that if we sometimes see that glycine is available, is not available because we don't have the synthesis factors, but we also see it sometimes that glycine is not available because it's being used up too fast. And glycine can be combined with arginine, and this happens when arginine is excessive. And so if we do AK testing, arginine would weaken, and the things we would use to try to get rid of the excess arginine so it doesn't deplete all of our glycine from other uses, we would use arginase enzyme and manganese. Both of these activate the urea cycle pathway to get rid of arginine. And again, it's well discussed in the QA course, especially in session 15. But we want to have adequate glycine, so we want to make sure we can make it. We don't want to have it depleted too much by excess arginine. So the liver detox pathway assessment of phase 2 glycination, we would confirm a PMS weakness or confirm a PMS strong in the clear, and we would, pectoralis major sternal relates to the liver. We challenge the strong pectoralis major sternal with a thymus thump. We actually thump over the thymus, something Dr. John Diamond talked about many, many years ago to stimulate thymus activity. We do it as a challenge. And if this weakens, we rub the liver Chapman's reflex while performing the thymus thump. Now, there's more to it than that. This is just the gist of it, how we can help the liver to decrease cytokines when they're elevated. We can also challenge with the cytokines, and we can use other nutritional support, as it says in 10, recommend nutrient support if recurrent and are clinically appropriate. And that would be the nutritional factors we talked about to support glycine. Sometimes other detoxification pathways are involved in glycine detox, in cytokine detoxification. The primary one is glycine. You could see glutathione as well and some other ones.
I think we may have lost Dr. Schmitt for a moment. He's frozen in space. There, you're back. Thank you. Go ahead with this slide.
Okay, thank you. We'll get to the next slide here. So theoretically, improving glycine availability, thus liver detoxification of cytokines, may be worthy consideration if confronted with a similar viruses that create a cytokine storm. Now, we've had good success where patients had excess cytokines following a flu or following some other disease process or some significant inflammatory activity in their body. We've had excellent success getting rid of those excess cytokines and changing significant symptoms. Some, if you ever get sick and you feel like you're having like perceptual disorders, or really just you look at TV and just kind of looks funny to you, or you're lying in bed and you have really weird dreams, those are from the cytokines that are affecting your brain. So these excess cytokines, when one is sick, creates a number of symptoms, like I say, distorted perception or weird dreams, and they also, of course, enhance the inflammatory process and the discomfort associated with the bug. But we haven't, of course, tried this with COVID-19, but the the idea is to consider that we had such good success getting rid of excess cytokines in patients who have other sources of them besides the cytokine storm. It seems to be worthy of consideration if confronted with similar viruses that create a cytokine storm. However, be aware there's no practical clinical experience or research that support this concept in the COVID-19. But I'm putting it out there because we've had such good success in other things. You can test the patient and find out. You can challenge the patient, challenge their liver. You can do the thymus thump we just talked about. If we can see if glycine or its cofactors negate it, and you can find out about your individual patient if glycine would be useful or not. I would never just give glycine, because glycine in its own right has a neurotransmitter effect and can have its own negative effects if you get too much of it. But if the patient tests for it, that's another factor. So let's now talk about Chapman's reflexes for the immune system. One other thing we want to talk about to help patients who have any type of infection and potentially the COVID-19 infection as well. Chapman's reflexes for the immune system are particularly the ones we're going to look at are for the thymus gland, which is about the on the right side, at about the fifth intercostal space, fifth intercostal space. What you do is you go up into the intercostal space and you go down about from the mid-axillary line, go down about 4 or 5 ribs and palpate in the intercostal space. You'll find when it's very tender when the thymus needs to be treated. You'll also find a weakness of the infraspinatus muscle on the right or sometimes bilaterally. The Chapman's reflexes for the immune system, the spleen is on the left side, go straight down the left at mid-axillary line to get down about the 7th intercostal space, give or take 1. And you'll find there's some tender areas. There's the Chapman's reflex for the spleen, which is associated with the middle or lower trapezius. Posteriorly, there's a spleen reflex at T7, T8 interspinous transverse space area in the back. So we have 2 reflexes we might want to look at. The idea of this reflex is that they will stimulate the thymus and the spleen, which particularly look at stimulating the adaptive immune system. Remember, we've got to be careful when we stimulate the adaptive immune system. We got to make sure we stimulate in the right direction. So there are muscles related to the immune system. The thymus is related to the infraspinatus, as we said, and the spleen is related to the middle and lower trapezius, as we said. Typically, if you have a thymus problem, I would look for the infraspinatus on the right first, could be bilateral. Typically, if you have a spleen involvement, I look for the middle or lower trapezius on the left, although it could be bilateral. Chapman's reflexes related to the immune system. These reflexes should receive soft tissue manipulation or rubbing, when they are tender and or indurated. That's what Chapman used to do. He'd find the reflex to be tender or indurated, feels like trigger points, a little tender to the patient, indurated to the palpation of the doctor, and then you would rub it. Or when their associated muscle is weak and the therapy localization to the reflexes takes place is positive. Often, only one immune system muscle weakness is present. However, correcting one unveils the other. In other words, if you have like infraspinatus weakness and you rub the Chapman's reflex for the thymus, you may have previously checked the middle or lower trapezius and they're fine, but after you fix the thymus, then the spleen shows up. Or vice versa, you find the lower trapezius, you rub the Chapman's reflex for the spleen, but there was no infraspinatus. But after you rub the Chapman's reflex for the spleen, all of a sudden the infraspinatus shows up. Sometimes they're layered one on top of the other. Decades of clinical experience suggest that treating the immune system Chapman's reflex will have a normalizing effect on immune status. Rubbing these Chapman's reflex has always appeared to support the patient's need to increase whatever immune function is necessary for recovery. So if they're fighting a pathogen or infections, that's one pathway. Making an anti-inflammatory effect, that's another way. The body seems to know what it needs when you want to have stimulus of these immune system reflexes. Now, again, we haven't done this in the COVID-19 virus, but throughout many, many decades, we've seen that patients who need more immune system attacking or fighting a bug, rub the Chapman's reflexes, it'll take it in that direction. Patients who need less immune system activity because maybe they're hyperinflammatory, they have autoimmune disease, rubbing the Chapman's reflex takes the body in that direction. The immune system knows which way it needs to go, and rubbing Chapman's reflexes seems to take it that way. The immune Chapman's reflexes must be treated, that is to say rubbed, for at least 2 minutes and up to 4 minutes to achieve optimal effects. We originally learned about the neurolymphatic reflexes or the Chapman reflexes, and you'd rub them for like 20, 30 seconds and be on with it. We've learned since that time, based on the work of Kevin Tracy at the National Institutes of Health, which came out in 2005, 6, 7, and consequently, that when we stimulate the spleen, for example, and this is his research on the spleen, you have to stimulate the spleen. He's the guy who stimulated the vagus nerve to stimulate the spleen that opened up the so-called vagal anti-inflammatory effect research. He's the guy who did all that original work. And he said when you stimulate the vagus to stimulate the spleen, you need to stimulate for at least 2 and up to 4 minutes because you have to stimulate the spleen, well, the white blood cells circulate through it, and as the white blood cells enter the spleen, they are re-educated as they go through the spleen, and they're making, like, for example, a couple of cytokines, but one in particular, excess tumor necrosis factor alpha, going into the spleen. If you stimulate the vagus while the white blood cells go through the spleen, they are re-educated and make less tumor necrosis factor alpha coming out on the other side, which is a pretty phenomenal finding. And Kevin Tracy at the National Institutes of Health said the spleen will re-educate white blood cells as they go through when it's being stimulated by the vagus. So we've observed that it's necessary to treat the Chapman's reflexes for the spleen and the thymus in a similar fashion for at least 2 minutes. As Tracy says, it takes at least 2 minutes for enough of the white blood cells to circulate. Of course, we know the blood circulates every minute, but it doesn't all go to the spleen or the thymus. So at least 2 minutes to get enough white blood cells circulating to get the anti-inflammatory effect in the spleen's case, and up to 4 minutes. Similarly, with the thymus, we found clinically to be the same thing, 2 to 4 minutes for rubbing the thymus reflex to theoretically let the blood get through there to cause the anti-inflammatory effect. So you just rub it or percuss it, or sometimes you have the patient rub it. So then patients must be instructed to rub the immune Chapman's reflexes as home care once you've determined that this treatment is indicated. So here they are again. The Chapman's reflex on the right is the thymus, 5th intercostal space laterally, and the spleen, the 7th intercostal space laterally, and also T7, T8 posteriorly. There are many, many natural healthcare practitioners commenting on how to treat COVID-19. With AK and manual muscle testing as a window on neurological and neurochemical and immunological function, we have a tool to help us identify what is most compatible with our patient's needs. So let's summarize the potential therapies to investigate. The innate immune system support, when interleukin-6 weakens, when TNF-alpha or IL-1 beta weakens, and glycine and cytokine detoxification. We could add to this the Chapman's reflexes as well. Let's summarize that. Remember, for the innate immune support, we would like to have our patients have adequate levels of vitamin A, C, D, and zinc, and we could use zinc lozenges at the first onset of any sore throat or upper respiratory symptom. Also andrographis, beta-glucans, like reishi or ganoderma lucidum, and astragalus. There are other substances that may work, but this is a good place to start in looking at your patients. When interleukin-6 weakens, trying to do things to help to avoid the cytokine storm. As the CRP elevates, the prognosis for patients gets worse, so we want to keep that CRP low. To lower that CRP, we have to lower these inflammatory cytokines that trigger the elevation of CRP. So with interleukin-6 weakens, we want to inhibit interleukin-6 using zinc, Scleria bicalensis, which is skullcap, berberine, and andrographis. Also avoid overtraining, because overtraining increases interleukin-6. Increase parasympathetic vagal outflow using stress reduction techniques or anything else you know how to do that. And you could use transcutaneous vagal nerve stimulation and so on. We also want to lower insulin. We want to deal with the factors, all the factors we deal with in QA step 20. Hyperinsulinism decreases vagus outflow and hence increases interleukin-6. So we don't want to do anything that stimulates insulin. Everybody says, well, eat a good diet and everything. Well, this is another good reason to avoid carbohydrates, and especially concentrated carbohydrates, as to give you lower interleukin-6 and avoid having excess cytokines. When TNF-alpha or interleukin-1 beta weakens, we want to inhibit TNF-alpha or interleukin-1 beta. Excuse me, again, we can look at curcumin, resveratrol, berberine, glutathione, again, skullcap, and again, vagus stimulation with TVNS. The glycine factors, we want to make sure the patient could be using actually glycine itself, but if they need more glycine, we can give it to them. But we also want to make sure they have enough synthesis of glycine using folic acid or 5-methyltetrahydrofolate, manganese, B6 in its P5P form, and also sometimes riboflavin. So we don't just give them all these things, we test them one at a time and see which ones they need in particular. And once again, if they have their glycine being depleted by excess arginine, if that's the case, we want to get rid of the arginine, we can use the arginase enzyme and manganese for that purpose.
It's very likely, as you have pointed out, that our patients are going to be calling us or communicating with us, asking for advice. If they happen to have these nutrients around, could indicator testing over the phone or by Skype using telemedicine kind of techniques be appropriate for identifying these nutrients?
Yes, I would think so. I think if you can't test your patients, you could use the indicator testing that we've used so successfully. Many of you have seen this in seminars. Whenever we do muscle testing, we also do indicator testing to verify the response that we get. You have the patient find some range of motion or some painful situation. If they have no pain, they can identify range of motion, how far they can bend, how far they can twist, and then test. Pardon me?
They might be painful at their CHAPMAN'S reflexes for the thymus and spleen, for instance.
Yes. So the pain might be on their palpation of these reflexes. And I would have patients, when I've actually treated patients over the phone with infections, I have them palpate their reflexes. They can find any range of motion, any pain, including the palpation of the CHAPMAN'S reflexes we talked about for the thymus or spleen, and then have them taste the substance. See if it changes the pain. See if it changes the range of motion. See if it takes the sensitivity of the CHAPMAN'S reflex down. This is something that's been practiced in AK for a long time. And these indicators can also give you a clue as to which nutrients are appropriate for your patients if you can't get your hands on them, as Dr. McCord said, using a telemedicine approach, which, we're not going to have these patients in our offices. They're going to be at home in sequestered, or they're going to be in a hospital. And so these are some ways we can help to identify their needs. And the indicator testing is, I always say, it's not just as good as muscle testing, it's actually better than muscle testing. Dr. McCord.
No, I know that I've already had calls, both the people who are not wanting to get exposed and wondering what to do for themselves, as well as people who might have been exposed and are wondering what to do if symptoms appear. And the issue is that those people are probably not going to be coming into your office. They might be, as you mentioned earlier, family, friends, or acquaintances, people that are in your inner circle, and that you might be hands-on able to treat. But my thinking is, considering the advice from the CDC and other agencies and governments, that most people are going to be sequestered unless they go to the hospital. And under those circumstances, they're going to be calling maybe their natural health care practitioner for some advice as to what they should do. And to try to throw all this at them at once may be an inappropriate, as you pointed out, mechanism. But if you were able to test them, even with indicator testing, over the phone, by Skype, watching them do things or talking to them through the process, they may be able to identify certain nutrients that may be helpful for them, not necessarily someone else in their family, but for them. And that, I think that is the clear indication that we want to forward, is that you can give all of these things to everybody, but you may be driving a particular thing that you don't want to be driving, or having an adverse response like you would with curcumin in some people. I am one of those, by the way. Curcumin in some people that may otherwise be helped by it.
So I've seen lists. In fact, I was accumulating a list of what people recommended the last 3 weeks. I stopped after about a week and a half. There's so many people had so many different recommendations. I think I got up to about 30 or 40 different herbs and other nutrient substances that people were recommending for this COVID-19, none of whom have ever treated it, by the way. And I just gave up on taking the list because I realized what's going to happen is some of those things are going to be inappropriate for some people. Some of those patient things might be inappropriate for anybody because of the nature of COVID-19, and no one's ever treated who's making all these lists. Hardly anyone has. So I decided what I would do is focus on, if I need to treat a patient, I can use that list, but I wanted to get to the core nutrients that we have covered in this webinar. You could try anything you want. Just make sure it fits with the pattern of the patient's immune system status at the time and matches their needs by using muscle testing if you can do it, or indicator testing if you don't have a direct access to them. So here again is the reference for the Internet Book of Critical Care. This is over 2 weeks out of date, but at the time it came out, it was very current, and the basic physiology that we reviewed is from this reference, and I would strongly recommend you look at it.
And actually, he mentioned in this that it would be updated as the days pass. So you'll see some of the references are from March 3rd. I didn't look at all of them because he was updating. I don't know how recent an update there is available, but he did mention that he would be updating the information as it changed, if and when that was the case. So please tell your friends about this webinar. This and all webinars are always available to our monthly webinar members. However, the replay of this special webinar on COVID-19 outbreak will be available to non-members by email link until Monday, and later on the QA YouTube channel and Facebook. So for all of you, we thank you, Dr. Schmitt, for helping to guide us through the clinical considerations that we might have, as opposed to this is absolutely what you do for every COVID-19 case, which is often seen in various ways on the internet. And thank you all for coming.